Good morning, friends. Myself, Dr. Pankaj, and welcome you all in Pedia Academy by Dr. Pankaj. So, today we are discussing recalls of fellowship entrance test which was conducted in 2025 Feb month. So, this is not exact recall. Basically, what we are focusing on the important areas or topics which are getting repeated in FET and NEET SS exam. So this is one of a kind video in which we will not discuss just answers of those questions. We will discuss in brief about those topics. So this will be very amazing and interesting series. So just stay tuned, and we are starting with, without wasting any further time, we are starting with this amazing discussion. Till then, do share, like, and subscribe this channel to motivate us for making other videos. Okay, so what we will do, we will start our discussion of this FET based exam topics. Which first question, that is LKM, liver kidney microsomal antibodies, are most commonly associated with this type of autoimmune hepatitis? Type 1, type 2, primary biliary cholangitis, or primary sclerosing cholangitis? What will be the answer? Just stop this video and think. Okay, the answer is type 2 autoimmune hepatitis. So just see, LKM antibodies are highly specific for type 2 autoimmune hepatitis, which predominantly affects children and young female. It is associated with CYP2D6 autoantigen. Just see this amazing looking table directly from Nelson. Type A autoimmune hepatitis and type 2 autoimmune hepatitis. Just see the antibodies LKM1 and LKM3 are associated with this type 2 autoimmune hepatitis along with liver cytosol type 1 antibodies. In type 1 autoimmune hepatitis, anti-nuclear antibodies, smooth muscle antibody, anti-actin antibody, and antibody against soluble liver antigen and liver pancreas antigen. Okay, we will go further down. You will see the geographic variations are worldwide. Age at presentation, at any age, the type 1 autoimmune hepatitis presents. Type 2 autoimmune hepatitis predominantly in early childhood, mostly female. 75% cases are seen in females, but in type 2 95% cases are seen in female. Clinical severity is broad range, and histopathological features are generally advanced in type 2 autoimmune hepatitis. Treatment failure are common, and relapse are common, and need for long term maintenance is common. So generally looking, we will just learn type 2 autoimmune hepatitis which occur in young children and female most commonly. This is severe variety, requires long term medicines, and this is actually associated with anti-LKM1 and anti-LKM3 antibodies. Quickly we are going to second question. So which is following not indispensable essential amino acid? So they are asking which is not essential amino acid. Options are leucine, lysine, tyrosine, histidine. So what will the answer? The answer should be tyrosine. Tyrosine is a non-essential amino acid because it can be synthesized by phenylalanine. Just remember the essential amino acid mnemonics: PVT, TIM, HAL, phenylalanine, valine, threonine, tryptophan, isoleucine, methionine, histidine, arginine, leucine, lysine. Just remember this, and you'll be good to go. Okay, question number 3. Which drug is contraindicated in tumor lysis syndrome? Allopurinol, rasburicase, febuxostat, and spironolactone. So which drug is contraindicated? Answer is spironolactone, because spironolactone as a potassium sparing diuretics can worsen hyperkalemia in TLS. Just see what are the common features of TLS are: hyperkalemia, hyperuricemia, hyperphosphatemia, and hypocalcemia. So these are three important: hyperkalemia, hyperuricemia, hyperphosphatemia, and hypocalcemia. So the drugs discussed: allopurinol prevents uric acid formation, rasburicase breaks down uric acid, febuxostat is xanthine oxidase inhibitor, The remaining drug, which is our answer also, the spironolactone, because it is potassium sparing diuretics. Next question. Acrodermatitis enteropathica. Which deficiency of which micronutrient? Everybody know it is zinc. So think, yeah, it is zinc. Acrodermatitis enteropathica is autosomal recessive disorder, and just remember the gene behind it. Gene is SLC39A4. So what are the clinical manifestations? We all know this is perioral and acral dermatitis, diarrhea, and alopecia. Next question will quickly go. So, what are the characteristic features of Alagille syndrome? Paucity of bile duct, pulmonary stenosis, uh, butterfly vertebrae, all of the above. So just I mark the answer, paucity of bile ducts. So, we'll see. So Alagille syndrome, just we'll discuss Alagille syndrome in brief. I have a video of Alagille syndrome in detail. You can see that video also in the link is in description. So Alagille syndrome is autosomal dominant disorder, mutation in JAG1 gene. So the salient features are paucity of bile ducts like cholestasis and jaundice, cardiac defects and pulmonary stenosis, skeleton anomalies, butterfly vertebrae, facial features, triangular face, deep set eyes. Okay, just see this amazing looking table and diagram from Nelson. These are showing posterior emprotoxon and butterfly vertebrae. These are very peculiar of Alagille syndrome. Other thing in liver, you able to see conjugated hyperbilirubinemia, dysmorphic facies, triangular appearance is very important, congenital heart disease, peripheral pulmonary stenosis, axial skeleton, butterfly vertebrae, and eye or posterior embryotoxon. So just remember these important pointer like jaundice, like triangular appearance, like peripheral pulmonary stenosis, butterfly vertebrae, and posterior embryo toxon. So these are very important for Alagille syndrome. So we will move to further question, that is 6. Which is the following characteristic feature of Alport syndrome? Alport syndrome again is a very important entity. Options are SN hearing loss, progressive neuropathy, mutation in COL-A4-5 gene, and all of the above. So we'll see the answer is all of the above. Just remember this is very important syndrome as per exam concern. Alport syndrome is characterized by mutation in COL4A5 X-linked dominant, which affects type 4 collagen, which affects kidney, cochlea, and eyes. So nephropathy, hearing loss, and ocular anomalies are seen. Next, we'll see move to question number 7. Which gene is defective in Abetalipoproteinemia? ABCD1, MTTP, LDLR, ApoE. Answer is MTTP. So this gene is defective. So A beta lipoproteinemia, also called as Basin Cronwyn syndrome, this is important, and the gene is also important, MTTP gene, leading to defective lipoprotein assembly with absence of apolipoprotein B. What are the symptoms of this disease? Steatorrhea, acanthocytosis, ataxia, retinitis pigmentosa, low triglyceride, absent LDL VLDL, and treatment is fat soluble vitamin supplementation A, D, E, K. We are going fast because we have to cover many questions in short span of period, but we will not compromise on explanation or the discussion of these important topics. My word output will be high, so bear me, and yeah, just we are moving towards next question. Question number 8. Which of the following translocation most commonly associated with Burkitt lymphoma? Translocation T1922, T814, T1114, T1517. The answer is T translocation 1814. So this is most common association, involves MYC oncogene translocation to IGH locus, which is not required as of now. Just remember this translocation is important, and it presents a jaw swelling, CNS involvement, bowel obstruction, and sporadic form. Next, we are discussing next question. The next question is question number 9. Which of the following is a common cause of vesicoureteral reflux, VUR? Posterior urethral wall, UP junction obstruction, vesicoureteral junction incompetence, and neurogenic bladder. What will be the answer? Just pause this video and think. Okay. The answer is vesicoureteral junction incompetence. So as we all know, this is the most common cause of this. We are going to next question. A 7-year-old child present with recurrent abdominal pain, jaundice, and palpable mass in right upper quadrant. What will be the most likely diagnosis? So hepatoblastoma, choledochal cyst, hydatid cyst, Wilson disease. Just think the answer. Answer will be choledochal cyst. So choledochal cysts are congenital cystic dilatation of bile ducts leading to obstructive jaundice and recurrent pancreatitis. Triad is abdominal pain, jaundice and palpable right upper quadrant mass. The treatment is surgical excision by hepatoyeynostomy. So this is important. The clinical presentation of choledochal cyst is typical. Next question. We are moving to next question, which is following amino acid, not a essential amino acid. So as we discussed earlier also, answer is tyrosine, and just remember essential amino acid mnemonics is PVT Tim Hall. I think this question is getting repeated. Okay. The next question, question number 12. Which of the following chromosome translocation is most commonly associated with Burkitt lymphoma? I think we have discussed it. Translocation 814 MYC IGH translocation is most common. Okay, just remember the additional point from this slide. T922 is seen in CML, T1114 in mantle cell lymphoma, T1517 acute promyelocytic leukemia. This discussion is fully action packed with lot of information. Basically, this is a very concentrated section of our discussion. Just pay attention and revise this section again and again, this video again and again, and you will get a lot of more information from this video. Okay, so as we discussed also, endemic Burkitt lymphoma presents with jaw and facial bone swelling. Sporadic Burkitt lymphoma presents at abdominal mass and bowel obstruction. Okay, next question number 13. So in this, which is not true about Onchua syndrome? Basically, this is new syndrome which has been appeared in exam. So just we'll discuss some important points. Okay, so actually true is all of the above. Just see what it is. It is a rare connective tissue disorder because features overlapping Marfan syndrome and Loeys-Dietz syndrome. Just remember, this is rare connective tissue disorder. Key genetic features because this is autosomal dominant, skeleton abnormalities, aortic aneurysm risk, and ocular anomalies. The diagnosis by genetic testing, treatment by beta blockers and lifestyle modification, and surgical intervention in aneurysm. Basically, this is a rare connective tissue disorder which resembles Marfan syndrome and Loeys-Dietz syndrome. Question number 14. So, 7-year-old child with recurrent abdominal pain and jaundice, we have discussed this. Answer is choledochal cyst. Okay. So, in this, we will discuss type of choledochal cyst in Tudani classification, which is very important for our exam. Just pay attention. Type 1. Type 1 is fusiform dilatation of common bile duct. So, this is fusiform dilatation of common bile duct, which is very common, and this is most common. Type 2 is diverticulum of CBD, as you are able to see. Type 3, it is choledococele. Type 4, multiple intrahepatic and extrahepatic cyst. You are able to see multiple intrahepatic and extrahepatic cyst. Type 5, Caroli disease, intrahepatic cyst only. So this is Tudani's classification of choledochal cyst, which is very important. Just pause this video and revise these cysts, which are very important. The diagnosis is by ultrasound, MRCP, cholangiopancreatography, treatment by surgical excision with hepatojejunostomy. Okay, so this is a question regarding RTA, which is following true regarding type 1 and type 2 RTA. Just go through these points or these options from this slide. I'm not repeating these options because these are very exhaustive. Just remember, I'm going to this table. Okay, so RT can be divided to proximal, classical distal, and generalized distal dysfunction. So just remember, in type, this is called type 4, this is called type 2, and this is type 1. Okay, so in type 4, potassium is high. This is very important. and urinary pH is less than 5.5 in proximal RTA, urine net charge is negative in proximal RTA, and fractional bicarbonate excretion is more than 10 to 15% during alkali therapy. Urinary UBP CO2, that is difference which is normal in proximal RTA, and associated features of proximal RTA is Fanconi syndrome. Associated feature with distal RTA is nephrocalcinosis and hyperglobulinemia and renal insufficiency in type 4. Just to summarize, type 1 RTA, distal RTA is defective H plus excretion leading to metabolic acidosis, nephrocalcinosis due to high urine calcium. Proximal RTA type 2 is defective bicarb reabsorption, urine initially alkaline then acidic once bicarbonate threshold is reached. Okay, if urine pH is more than 5.5, it is distal RT and proximal RT less than 5.5. So just remember this table. This is very important. Just pause this video. Just take a deep breath and just remember if urine pH is less than. Just remember this proximal RT. If urine pH is less than 5.5, urine net charge is negative, and fractional bicarbonate excretion is more than 10 to 15% during alkali therapy, and response to therapy is least responsive, and Fanconi syndrome is associated. It is proximal RTA. Okay, next we are moving towards to 16. A 2-year-old child with history of swallowing a button battery, which will be the best immediate management? Weight, endoscopic procedure, laxative, and abdominal X-ray. So a child has ingested a button battery. So the answer is urgent endoscopic removal if lodged in esophagus. Okay, so just remember once and for all, if button batteries are in esophagus, okay, just remove them. If they are in esophagus, just remove them. If they are in stomach and asymptomatic, monitor with serial X-ray. If symptomatic child is there, immediate removal of regardless of location. So just remember, if button battery is in esophagus, just remove it. If it is stomach and beyond, just wait with serial X-ray. Any time it is symptomatic, just remove any means by endoscopy or surgery. Okay, so question number 17. This is according to Paris classification. What does E2S2 signifies? Basically, what this means? This is actually not Paris classification. This is classification of UC, which signifies the E2S2 classification. Okay, without wasting your time, I'm just taking you the Montreal classification. It is called. This is very important. Just remember, this is E1, E2, E3. This is severity, and this is site. So this is site and this is severity. Just remember, the E1 is proctitis, means related to rectum. E2 is left-sided distal, limited to splenic fracture and fracture. E3 is pancolitis, means it is whole colon. Just remember, E1 is rectum, E2 is left side, and E3 is pancolitis. Similarly, for severity of these disease, S0 is remission, S1 mild, S2 moderate, S3 severe. So how you will classify this? If just see, if 4 or less stool per day, it is S1 mild. If it's 4 stool per day, minimum sign of systemic symptoms is called S2, and if it will be called S3 if 6 or more bloody stool per day, pulse rate more than 90 beats per minute, temperature more than 99.5, HB less than 10.5, and ESR more than 30. So just remember the Montreal classification, that is site and severity base for ulcerative colitis. Coming back to our question, E2S2 as we discussed in this scenario. So our answer will be left-sided E2 because it is left-sided colitis, and S2 moderate disease. This question is very important, and this is actually not, this is uh, classification is called Montreal classification. Okay, this is Montreal classification. We are moving towards okay, We are moving towards next question, question number 18. A 3-year-old child is diagnosed with Wilms tumor. Imaging showing tumor confined to kidney with no vascular invasion. What is the correct stage according to National Wilms Tumor Study classification? So stage 1, stage 2, stage 3, stage 4, stage 5. Answer is stage 1. Okay. So just see if just this is a rough idea. If tumor is limited to kidney and completely excisable, this is stage 1. If beyond kidney but completely excisable, stage 2. Residual tumor remains in abdomen, stage 3. Stage 4, hematogenous spread. And stage 5, bilateral renal involvement. Just remember this important table from Nelson, which actually signifies the same we have discussed. Tumor confined to, just see, tumor confined to kidney. Tumor extend beyond kidney but completely resectable. 3, residual tumor beyond this. Fourth, hematogenous metastasis. And fifth is bilateral renal involvement. Okay, just see these important syndromes which are associated with Wilms tumor. Just go through this table. This is very, very important. Danny-Dresch syndrome, Frazier syndrome, Weger syndrome, and Beckwith-Widman syndrome, and Bloom syndrome. Okay, WT1, WT1, and the 11p3 WT1. So these are n phenotypic features. Just go through this table. This table is very, very important. Wilms tumor predisposed condition, you will get to know the importance of this. Next, question number 19. Which of the following statement true regarding serological markers in inflammatory bowel disease? So just go through these options, and the answer will be P and K is more common in ulcerative colitis, while ASCA is more common associated with Crohn's disease. So just remember P and K. If someone say P and K, it will go with ulcerative colitis, and ASCA, anti-Saccharomyces cerevisiae antibodies, Crohn's disease. So this is very, very important. Okay, just remember this comparison of Crohn's disease and ulcerative colitis. We have things are common. Just remember one disease. Okay, so just see about this ulcerative colitis. Rectal bleeding and diarrhea are more common. Okay, rectal involvement is universal. Pyoderma gangrenosum is present. Okay, colonic disease is 100%, and toxic megacolon is present. Sclerosing cholangitis is present. Okay, transmural involvement is common. Okay, crypt abscess are common. So just remember these things. You will see counterpart of these, but as of now you have to go through this table once. But as of now, just see ulcerative colitis, rectal bleeding, diarrhea, rectal involvement, pyoderma gangrenosum, colonic disease, toxic megacolon, sclerosing cholangitis, transmural involvement, crypt abscess are common. Okay, so we are moving to question number 20, which is following a true statement regarding diagnosis of celiac disease. Okay, so just go through the options again, and I'll not be repeating these options. So the answer will be child with high TTG and positive HLA DQB can be diagnosed without biopsy. Basically, if you want to diagnose the child without biopsy, the TTG IG level should be more than 10 of normal limit, positive EMA IG antibody in HLA DQ2 DQ8 positivity. So if the TTG IG are more than 10 of upper limit and endomycin antibodies are positive, you can diagnose this patient without biopsy. This is the crux of this question, and this is very important, very uh, interesting question. Next, a father with porphyria is concerned with her child risk. What is the best screening test for child? PBG test, genetic testing, RBC protoporphyrin, hemoglobin, electrophoresis. Basically, they are saying which test is more common or more screening test of porphyria. So answer is genetics testing with specific enzyme deficiency. Oh, so this is like AIP deficiency, and lead poisoning. Genetic testing is the most definitive testing of hereditary porphyria. Next question. At what gestational age the Palmer-Gress reflex first appearing fetus? 20, 24, 28, 32. So the answer is 24 weeks. Palmer grass appears at 24 to 26 week of gestation. It well developed by 32 week of gestation persists until 4 to 6 month of life. Just remember this important table, which is actually developmental delay upper range. So this is very important. I am not repeating this table. Just go through, just pause this video and go through this table. This is very much important. So next we are going to question number 23. Which of following endoscopic finding is characteristic of ulcerative colitis? Skip lesion, continuous mucosal involvement, aphthous ulcer, stricture and transmural involvement. Okay, the answer is continuous mucosal inflammation with loss of vascular pattern is the most common pattern in ulcerative colitis. Okay, so we'll discuss this difference later, but as of now just remember ulcerative colitis, this continuous colonic inflammation is most common, loss of vascular pattern granular mucosa is most common, and Crohn's disease present with skip lesion, cobblestoning and transmural inflammation. Again you are seeing a fellowship entrance test previous years this year question. This is a recall video, and so I'm going very fast, so to accumulate all the question in a definitive period of time. Question number 24. Okay, so this question is 24. Which following image is most characteristic of medulloblastoma? Just go through the option, okay, once, and the answer is a well-defined midline posterior fossa tumor with hydrocephalus. So just see, medulloblastoma is most common malignant brain tumor in children, arises from cerebellar vermis. MRI findings are well-defined midline mass, hyperdense on CT, hydrocephalus due to fourth ventricle compression. Histology of this is small round blue cells, Homer right rosettes. Treatment is surgery, chemotherapy and radiation. Okay, we are moving to next question. What is the first line treatment of posterior fossa brain tumors like medulloblastoma in children? Chemotherapy, surgical resection, radiation, immunotherapy with checkpoint inhibitors. So the correct answer is surgical resection followed by radiation. So posterior fossa tumor in children includes medulloblastoma, astrocytoma. The standard treatment in medulloblastoma is surgical resection. Radiation is avoided in less than 3 years. That's why in children, due to radiation hazard, surgical resection followed by radiation of low dose radiation is the treatment of choice. Question number 26. Okay, according to ISN RPS classification, which class of lupus nephritis is characterized by subendothelial immune deposit and wire loop lesions? Class 1, class 2, class 3, class 4. Just see this question and the answer will be class 4, diffuse lupus nephritis. Okay, so class 1 in minimal mesenchymal changes, class 2 is mesenchymal hypercellularity, class 3 is focal proliferative less than 50% glomeruli, class 4 is diffuse proliferative wire loop lesions, class 5 is membranous, and class 6 is advanced sclerosing this lupus nephritis. Just see this important table from Nelson. This is showing minimal mesenchymal proliferative, focal proliferative, diffuse proliferative, membranous and advanced. Just go through this important table once and you will get to know what it contains inside. Next question. Which the following is true regarding Glasgow scale? So just go through these options by yourself and I'll discuss. GCS less than 8 is an indication of severe brain injury. So this is GCS. I will not discuss the GCS in detail. I'll directly go to next question. The 5-year-old child with 30% of body surface area burn requires fluid resuscitation using Parkland formula. How much Ringer lactate should be given first 24 hours? Okay, the Parkland formula is for this is actually you have to remember the Parkland formula 4 into time weight kg, okay, body surface area. So just remember 420 into 30, it is 2400 in first 8 hours and 2400 in next 16 hours. Total in 24 hours it is 6 liters. Okay. Next question. Question number 13. Okay, so this is actually 13-year-old child which with a mother diagnosed with von Willebrand disease. Okay, so just we are saying 13-year-old child with mother diagnosed with volumetric disease present with epistaxis for 1 month. Coagulation profile is normal, which is the most likely diagnosis. Okay, so vitamin K, von Willebrand hemophilia, and factor 5 leading mutation. The diagnosis is von Willebrand mutation. So this is most common inherited bleeding disorder associated with epistaxis, bruising, menorrhagia, and vitamin K deficiency factor. These. Okay, I'm going fast because I can't concise all. Otherwise, I'll not able to concise all the questions in this definite period of time. Okay, question number 30. Which of the following is most characteristic radiological finding in distal intestinal obstruction syndrome and cystic fibrosis? Just go through the option once. Answer will be dilated bowel loops of with fecal material in terminal ileum. Just see these are dilated bowel loops as you able to see, and the fecal matter is also seen. So, DIOS occur in cystic fibrosis due to insipid stool and mucus in ileum. X-ray finding are dilated bowel loops, bubbly stool and ileum. Management by rehydration, laxative and PEG. Question number 31. What leads to lead pipe appearance in abdominal X-ray? This is answer is straightforward. Lead pipe seen in ulcerative colitis. Just see this image. This is lead pipe. What led to lead pipe? Lead pipe is loss of hostration due to chronic inflammation and fibrosis in ulcerative colitis. On the other hand, the Crohn's disease develops skip lesions, cobblestoning and fistula. Next question is question number 32. Which condition is commonly associated with fine cone bladder on imaging? The options are PUV, neurogenic bladder, vesicoureteral reflex, UPV, obstruction. Just see this cone looking like bladder of neurogenic bladder. So pine cone bladder is small trabeculated bladder with loss of normal shape seen in neurogenic bladder. So this is important. The next question, what is the role of hydrocortisone in neonatal sepsis? So this is used in refractory septic shock due to adrenal insufficiency. So this is all we know. This hydrocort used in refractory septic shock due to adrenal insufficiency. Next question, a newborn has poor feeding, lethargy, urine that smell like burnt sugar. Okay, so the burnt sugar appearance, which is important, which is of MSUD, maple syrup urine disease, due to accumulation of leucine, isoleucine, valine, leading to neurological toxicity. Next question, at what age urine osmolarity reached at adult level? The answer is 1 year. So adult level of urine osmolarity more than 800 milliosmol per kg are reached by 12 months. Okay, next question. Question number 36. What is the treatment of choice of Acrodermatitis, enteropathica, zinc supplementation? We have discussed earlier, also not discuss later. Okay, question number 37. A child with pancytopenia, cephalotus spot, and thumb abnormalities having suspected to have Fanconi anemia. What is the best confirmatory test? This is bone marrow biopsy, chromosomal breakage test, HP electrophoresis, serum B12 level. The answer will be chromosomal breakage study with DEB and MMC. So this is very, very important, and we'll discuss this topic. We have discussed this topic in detail. Just go through my videos. Okay, you will find inherited bone marrow failure syndrome. We have discussed Fanconi anemia in detail there. Just go through the playlist. Question number 38. Which hemoglobin electrophoresis pattern is seen in beta thalassemia major? So just go through the option once. The answer will be absent HbA and increased HbF and HbA2. This is a very simple question, all we know. Next question is question number 39. Which is the best approach for nutrition support for acute pancreatitis? Okay, NPO, early enteral feed, TPN, high fat oral diet. Just remember, this is very pitfall. Early enteral feed via nasogastric tube is the most common modality for this pancreatitis. Okay, question number 40. A 5-month-old infant present with vomiting, hypotonia, developmental delay. MRI shows hyperintensity and bilateral mammillary bodies and basal ganglia. What nutrient deficiency? So vitamin B12, B1, biotin, iron overload, what will be the answer? The answer should be B1 deficiency. So thiamine B1 deficiency leads to Wernicke's encephalopathy. Biotin deficiency leads to seizures and alopecia. Iron overload, basal ganglia deposition in neurodegenerative disease. Next, question number 41. Which chemotherapy agents is most commonly associated with reticular hyperpigmentation? Options are bleomycin, cisplatin, uh, methotrexate, cyclophosphamide. Answer is bleomycin. The bleomycin toxicity leads to cutaneous hyperpigmentation along with pulmonary fibrosis and Renal phenomena. Next question is 42. A 4-year-old child presents with respiratory distress and pulmonary infiltrate. What will be the next step? Just go through the options once. Answer will be start broad spectrum antibiotic, because this is pediatric pneumonia with respiratory distress. We have to start broad spectrum antibiotics. Okay, the next is question number 43. A diabetic child with neutropenia. A diabetic child with neutropenia presents with fever, hemoptysis, and cavitating lung lesion. Which options are more likely? Aspergillus, mucormycosis, histoplasma, cryptococcus. The answer will be mucormycosis. So mucormycosis is in immunocompromised patients, cavitatory lung lesions. Okay. Next question, question number 44, which is the following: note a feature of Charles syndrome: coloboma, congenital heart disease, Hirschsprung disease, genital abnormalities. The answer will be Hirschsprung disease. Charles syndrome seen in CDHD mutation. Just go through the Charles syndrome expansion: coloboma, heart disease, corneal atresia, retardation, growth and mental, genital abnormalities, ear abnormalities. Next question, question number 45. Which gene is deleted in DJO syndrome? TBX1, PEX6, NF1, CFTR. So answer will be TBX1. So DJO syndrome, 22q11.2 deletion, defective TBX1 gene. So we have discussed Catch-22 syndrome. In Catch-22 syndrome, cardiac defects, C4 cardiac defects, A abnormal facies, T thymic hypoplasia, C cleft palate, H hypocalcemia. Next question, question 46, we'll discuss. So in this, which is following is a characterized of Kikuchi Fujimoto disease. This is actually the difficult name to pronounce. So the answer is presence of necrotizing histiocytic lymphadenitis. Okay. So this is benign self-limited cervical lymphadenopathy, and presence of necrotizing histocytic lymphadenitis is the hallmark. The histology is necrotizing histocytic lymphadenitis, and the treatment is supportive care. The next question, question number 47. A 3-year-old child with recurrent UTI present with persistent fever despite appropriate antibiotic. What will be the next step? Continued antibiotic, USG, VCUG, and broad spectrum antibiotic. Answer will be perform renal ultrasound, because in this condition evaluate for renal abscess and obstruction. Ultrasound will be next. Question number 48. Deficiency of which component increase susceptibility to Neisseria meningitis infection? The options are C1 inhibitor, C3b, C59, factor H. The answer will be C5 and C9 membrane attack complex. Okay, so C5 and C9 MAC deficiency, recurrent Neisseria infection. The management will be meningococcal and lifelong antibiotic. So we are in middle of discussion of this amazing discussion of FET based questions. I have created many videos of Nelson based, which are important for FET exam along with NEET exam. Just go through the playlist, which includes very important high yield topic, and we have discussed in detail. Unlike this video, we discussed every topic in detail, and I have a short series of Nelson based tables and images discussion. Just go through it. It will be your ready to go source for your exam and practice also. So coming back to the topic, next question is question number 49. Which pulmonary function test abnormality seen in scoliosis? The options are increased residual volume, increased vital capacity, decreased vital capacity, decreased total lung capacity. So the answer is decreased lung capacity. So scoliosis causes restrictive lung disease. VC is decreased, TLC is decreased, FEV1 FVC ratio is normal or increased. Next question, question number 50. Which of the following is a characteristic of Indian childhood cirrhosis? ICC, copper deposition in hepatocyte, alpha-1 antitrypsin deficiency, hepatitis B infection, increased serum iron levels. The answer will be copper deposition in hepatocyte. So this is progressive liver disease due to excessive copper intake. Next question. Which of the following Y-linked genetic disorder, DMD, hemophilia A, Swyer syndrome and AIS? The answer will be Swyer syndrome. So this syndrome actually from father to son mutation in SRY gene. Next question. A 10-year-old child with traumatic brain injury, eye-opening, painful stimuli, just calculate the GCS score. This is easy question. I will answer is 9. I will hand over this question to you. Just go through this question and calculate the GCS score. Okay, next question is question number 53. Which type of brain herniation is most likely in a child with unilateral ptosis and raised intracranial pressure? Just go through this image. This is actually cingulate herniation, this is transcalvalier, this is downward, this is uncal. As of now, our answer of this question is uncal herniation, because uncal herniation is transtentorial, compressed oculomotor nerve, ipsilateral ptosis, and fixed dilated pupil. Okay, next question. Question number 54. Which nerve roots are primarily affected in conus medullary syndrome? The answer is T12 to L2. Just go through this important looking table of conus medullary syndrome and coda equina syndrome. Just pause this video and go through this table. You will get to know this. If you want to see more detailed video on this conus medullary syndrome, we will discuss in separate video. As of now, it is out of scope of this discussion. So conus medullary syndrome is T12 to L2 level. Features are early bladder bowel dysfunction, lower limb weakness, hyporeflexia, and coda equina syndrome versus asymmetric weakness and lateral bowel involvement. Okay. Question number 55. A 6-month-old child presents with progressive jaundice, pruritus, and hepatomegaly. Liver biopsy shows bile duct paucity. We have seen it. This is Alagille syndrome. Okay. uh, oh, sorry, this is actually no, this is not Alagille syndrome, just this is PFIC. So PFIC is cholestatic liver disease, severe pruritus, hepatomegaly, and normal GGT levels. Okay, so stage 2 AKI according to KidGo criteria. Okay, stage 2 AKI, so just remember, stage 2 means serum creatinine raised by 2 to 2.9 of baseline. Stage 1, stage 2, stage 3. Just go through these criteria once. I'll not be discussing here because this is a separate video and separate discussion. This is very exhaustive topic. Next is question number 57. A 15-year-old male present with progressive night blindness, ataxia, peripheral neuropathy, examination showing scaly ectatic skin, and SN hearing loss. The answer will be Refsum disease. So Refsum disease is paroxysmal disorder due to phytanic acid accumulation due to defect in PYH gene. Clinical features are progressive peripheral neuropathy, cerebral ataxia, retinitis pigmentosa, SN hearing loss, and ichthyosis. The diagnosis will be with elevated phytanic acid, electrophysiology, abnormal nerve conduction, strict dietary restriction with phytanic acid containing foods. Okay, the next question is question 58. The 10-year-old child had trauma with GCS 8. What will be the best immediate next step in management? If GCS 8 is there, you have to do immediate endotracheal intubation. Next question, question 59. Which of the following is not essential amino acid? I think we have discussed this question, so this is a repeat question. Answer will be tyrosine. Just go through this mnemonic once. Okay, kidney having adult concentrating ability, we have discussed it. Answer is 1 year. Okay, so what is the best describe, question number 61, best describe the position of horseshoe kidney? So the high riding kidney, normal position but rotated, low lying kidney, pelvis, these are options. Okay, so the answer will be the horseshoe kidney, low lying in pelvis, fused at lower pole. So this is low lying of kidney fused at lower port. It is associated with hydronephrosis, increased risk of stone and infection. Okay, question number 62. Okay, a 12-year-old child present with sudden onset of headache, photophobia, neck stiffness. What will be the next best step? CT, lumbar puncture, MRI, and EEG. Answer will be CT, brain without contrast, because uh, we have to rule out bleeding. Lumbar puncture is done only if CT is negative, but suspicion remain high. So just remember, we are discussing this discussion series on FET. So I am going fast. My word output is high, but look at the essence. We are covering as many questions as we can cover in this session. Okay, next question is question number 63. What genetic syndrome is strongly associated with JMML? Down, Noonan, Marfan. Okay, the answer will be Noonan syndrome. So Noonan syndrome is rare pediatric leukemia associated with the high risk of JMML. Next question is what is the best approach for nutrition support in acute pancreatitis? I think we have discussed it. So this is early enteral feeding by nasogastric tube. Next question. A child has uh, fever more than 14 days, maculopapular rash, hepatosplenomegaly, and generalized lymphadenopathy. What will be the likely diagnosis? Options are Kawasaki, ALL, systemic juvenile arthritis, dengue fever. The answer will be systemic juvenile idiopathic arthritis, because this is also called still disease. Triads are coordinated fever, rash, and arthritis. Okay. Question number 66. So this question is, according to Jean Piaget theory of cognitive development, which stage infant develop object permanence? So just answer is sensory motor stage. Explanation: sensory motor stage is 0 to 2 years. Learn objects permanence. uh, Pre-operational 2 to 7 years. Symbolic play, egocentrism. Concrete operational play is 7 to 11 year. Logical thinking develops, and formal operation 12 plus year. Abstract reasoning are present. Just go through these important terminology, and these are very important. Next question, question number 67. A 6-year-old boy with polyuria, nephrocalcinosis, low molecular weight proteinuria, genetic analysis reveals a mutation in CLCN5 gene. So this gene itself shows the diagnosis. Okay, options are Barter, Dent, Fanconi, and Port syndrome. The diagnosis of this is Dent disease. So Dent disease is auto X-linked recessive proximal tubulopathy characterized by mutation in CLCN5 gene. Key features are low molecular weight proteinuria, hypercalciuria, and polyuria rickets-like feature. So diagnostic by genetic testing for CLCN5 mutation. Treatment by a thiazide diuretics. Okay. Question number 68. Which of the following radiographic sign is most commonly seen in CHPS? String sign, double bubble sign, thumb printing sign, corkscrew sign. So the answer is string sign. CHPS is characterized by progressive non-bilious vomiting in olive-shaped mass. Ultrasound findings are showing thickened pyrotic mass. This is more than 4 millimeter and elongated canal. Okay. The next question is 69. A 3-month-old infant presented with recurrent infection, jaundice, and low serum IgG less than 20 and decreased C3 complement level. What will be the most likely diagnosis? X-linked agammaglobulinemia, hyper IgM syndrome, complement C3 deficiency in autoimmune hemolytic anemia. The answer will be complement C3 deficiency. So C3 deficiency is recurrent bacterial infections. Okay, encapsulate bacteria, streptococcal pneumonia. Next question, question number 70. A 6-month-old infant develops seizures and hypoglycemia after starting sweet cereals. What is the most likely diagnosis? Options are galactosemia, hereditary fructose intolerance, maple syrup urine disease, and glycogen storage disorder. The answer will be hereditary fructose intolerance. So this is due to aldolase B deficiency. Symptom appears when fructose is introduced. Key features are vomiting, lethargy, and hypoglycemia, and strict avoidance of fructose and sucrose and sorbitols are recommended. Next question, question number 71. In this, newborn with jaundice, hepatomegaly, cataract presents with sepsis due to E. coli. What will be the most likely diagnosis? Options are neonatal sepsis, galactosemia, G6PD deficiency, MSUD. The answer will be galactosemia. So galactosemia is autosomal recessive disorder due to GALT deficiency due to toxic accumulation of galactose 1 phosphate. The clinical findings will be jaundice, cataract, E. coli sepsis. The diagnosis by positive non-glucose reducing substances in urine. Okay, question number 72. Which of the following is the first line treatment of superior mediastinal syndrome malignancy in children? High iodose steroid, a broad spectrum antibiotic, thoracotomy, immediate surgical biopsy. The answer will be high dose IV steroid because it is caused by compression. Okay, and treatment will be due to IV steroids. Okay, yeah. Then, what is the following? Next question: what is the following characteristic of Onchua syndrome or Eurofacial syndrome? So just remember, this is alien syndrome to us. So just remember, this is Eurofacial syndrome. It is a genetic disorder. It is characterized by HPSE2 mutation. It shows dysmorphic facial expression, paradoxal smiling, neurogenic bladder with vesicoureteral reflex, recurrent UTI and renal failure if untreated. The next question, which of the following is not a common feature of chronic kidney disease in children? Options are metabolic acidosis, anemia, GH excess and secondary hyperparathyroidism. Answer will be GH excess. So GH excess is not found. GHR levels are normal or low in CKD, leading to growth retardation. This is very important concept. Next question is question number 75, which is the most common, which the following condition is not a common cause of proportionate short stature in children: GS deficiency, constitutional growth delay, Turner syndrome, hypothyroidism. The answer is Turner syndrome. Turner syndrome typically presents with disproportionate short stature, proportionate short stature seen in growth hormone deficiency, constitutional growth delay, and hypothyroidism. Okay, next question. Again, the repeat the Piaget developmental theory of the permanent seen in which stage? Sensory motor stage. So just revise these again: sensory motor, pre-operational, concrete operational, and formal operational. Okay, the age and along with the features of these. Question number 77. Which of the following is a classical clinical features of renal artery stenosis in children? Hypertension, hematuria, polyuria, recurrent urinary infection. The answer will be hypertension resistance to medications. Okay. The next question, question number 78. Okay. So 6-year-old child presents urinary mass, dilated pupils, hemiparesis, the most likely type of brain herniation. The answer will be uncal herniation. We have discussed this topic in detail in previous video. So, what is the gold standard diagnostic test for eosinophilic esophagitis? Barium swallow, endoscopy, biopsy, esophageal manometry, pH monitoring. The answer will be upper endoscopy and biopsy. Okay, the biopsy showing more than 15 eosinophilic per high power field. Question number 80, I think, yeah. Which of the following classic feature of Caroli's disease? So, just go through these option once. Answer will be cystic dilatation of intrahepatic bile ducts. We have discussed it. Okay, so we have discussed the important questions which I received so far. So, if you have any other questions from this exam, just message me or just type in comments. If you want discussion on some important topic of this exam in detail, like you want many topics I have discussed in exam, so many topics I have discussed in my video series. If you want any other topic which should be discussed in detail, just message me. We will discuss those topics in detail. Till now, do share, like and subscribe, and just show some appreciation of this effort. I will be discussing many other exam questions also, and I will be continuing the amazing series of NEET SS pediatric previous test topics. So the next topic in that series will be coming soon. So just stay tuned and do share, like and subscribe.